syphilis is through sexually transmitted disease. Risk factors are unprotected sex, homosexuals, and HIV co-infection, whereas congenital syphilis is through transplacental spread. Mother can acquire infection during pregnancy, usually after 10 weeks, or she can also acquire it just before pregnancy. Stages of syphilis, it is important because it determines the duration and extent of treatment. Primary syphilis, it happens after an incubation period of 3 weeks. It is characterized by a painless chancre or ulcer that can happen on any part of the body, usually on palm and soles, and on genitalia. Chancre is more on genitalia, whereas maculopapular rash is on palm and soles more. This resolves on its own. Secondary syphilis occurs 6 to 8 weeks later. It is characterized by maculopapular rash and lymphadenopathy. Uveitis happens in 10% of cases. This is a characteristic maculopapular rash in secondary syphilis. Latent syphilis, this happens after secondary disease, secondary phase, and latent period can range from 1 year to many years. With the treatment, penicillin, tertiary syphilis is a lot less common nowadays. Only 1/3 of untreated cases reach to that stage. It is subcategorized as benign tertiary syphilis. Its characteristic lesion is a gummatous lesion, which is a soft neoplastic tumor-like lesion. Then there is cardiovascular syphilis, which can be characterized by aortitis, aortic regurgitation and dissection, and neurosyphilis. In 5% of patients of tertiary syphilis, uveitis happens, and ocular syphilis at this stage particularly is considered a part of neurosyphilis, as our eye is a continuation of brain. Many physicians consider any syphilitic uveitis to be a part of neurosyphilis. This is a gummatous lesion on forehead. This is a soft inflammatory lesion. This is a table showing ocular and systemic manifestations at different stages of syphilis. We can see that primary syphilis is characterized by a chancre, which is an ulcerated, painless lesion. It can happen in any part of the body, including the eyelid or conjunctiva. Whereas secondary lesion is characterized by maculopapular rash and generalized lymphadenopathy. Patients can also develop symptoms of sore throat or fever, meningitis, whereas ocular features can be uveitis, episcleritis, scleritis, optic neuritis, retinitis, chorioretinitis, and interstitial keratitis. There will be no symptoms or signs in latent syphilis, whereas tertiary syphilis presents with cardiovascular and CNS disease, and in ocular features there will be optic atrophy, chorioretinitis, and Argyll-Robertson pupil. Now, anterior uveitis, this is the most common feature of syphilitic uveitis or ocular syphilis. It can be both granulomatous or non-granulomatous. It is bilateral in 50%. Characteristic lesion is roseoli or dilated iris capillaries, iris nodules, which are present in only tertiary disease. Anterior uveitis, unlike tuberculous uveitis, can present solely as well. ज़रूरी नहीं है कि इंटरमीडिएट और पोस्टीरियर यूवियाइटिस भी साथ मिले इसके, इसलिए ये हर यूवियाइटिस के डिफरेंशियल डायग्नोसिस में आएगा. This is colored photograph. In the first picture we can see dilated iris capillaries or roseoli. Second picture is not very clear. There are mutton fat capes, and bottom two pictures are showing iris nodules. Posterior uveitis, it can be both unilateral or bilateral and uni or multifocal. Most common presentation is uni or multifocal chorioretinitis with associated vitritis. Hallmark of this posterior uveitis is acute syphilitic posterior placoid chorioretinitis. This presents with yellow plaque-like subretinal lesion in posterior pole. It is accompanied by vitritis more often. We can see this is a colored fundus photograph showing acute posterior placoid chorioretinitis. There is a yellow plaque-like subretinal lesion. On FFA, it shows early hypofluorescence and late hyperfluorescence with staining owing to that lesion. Other less common ocular features can be serous retinal detachment, retinitis, which can be unifocal or multifocal, associated vasculitis, which can involve both arteries and veins, and it can also be occlusive, retinal vein occlusion और artery occlusion दोनों हो सकते हैं. और जब रिजॉल्व होते हैं लीजन्स तो पिगमेंटरी रेटिनोपैथी डेवलप करती है. Optic neuritis and neuroretinitis can also happen. Also, we can find intermediate uveitis. Again, this first picture is showing iris roseoli. Second picture is showing macular star and chorioretinal infiltrates. Third picture is showing acute posterior placoid chorioretinitis, and in fourth picture we can see chorioretinal scars, multifocal chorioretinal scars. We can see similar picture in PRP scars or in retinitis pigmentosa as well. So that can be in differentials as well, based only on the chorioretinal scars. Then we can also get optic neuritis. It is recommended that in any patient with optic neuritis, with papillitis and macular star, we should consider syphilis as a differential diagnosis. Other ocular features can be episcleritis and scleritis, interstitial keratitis, conjunctivitis, Argyll-Robertson pupils, and extraocular motility defects. This is a colored picture showing scleritis and episcleritis. Anyone, how can we differentiate if a lesion is episcleritis or scleritis? Anything else? Any pharmacological test? How will we do that? We will put a drop of phenylephrine 2.5% or 10%, and we will check it again after 30 to 45 minutes later. And in episcleritis, it will blanch, whereas it will be same in scleritis. Investigations, it includes appropriate evaluation, systemic evaluation, and history by a genitourinary physician. Serological tests are the mainstay of diagnosis, and they include both treponemal and non-treponemal tests. Non-treponemal tests are VDRL and rapid plasma reagent tests. They are important in identifying the disease activity, but they can be false positive. Treponemal test, fluorescein treponemal antibody absorption test, and treponema pallidum hemagglutination test, they are highly sensitive and specific. However, they cannot differentiate whether a disease is active or a patient had previous disease which has been treated. Lumbar puncture in case of neurosyphilis, CSF analysis can also reveal treponemes. And HIV co-infection, HIV can also present along with syphilis. This is picture showing criteria for testing for syphilis. We do non-treponemal tests, VDRL and RPR, that is rapid plasma reagent test. They show disease activity, however, they have high false positivity rate. Treponemal tests, as we discussed previously, TPHA and FTA-ABS, they are more sensitive and specific. However, we cannot differentiate whether a disease is active on this test. We can see that FTA-ABS becomes positive in very early disease and remains positive throughout the disease, whereas VDRL becomes negative in later disease. Treatment is under the care of genitourinary physician. Penicillin is the drug of choice. It is one of the very few diseases that can be treated effectively with antimicrobial therapy, even in co-infection with HIV. Delay in treatment can result in loss of vision and also serious cardiac and neurological complications. Patient can develop meningitis, cranial nerve palsies, also aortic dissection. So this is a serious disease. This is stage of disease and treatment according to, in response to that. Mainstay of treatment is penicillin. However, in penicillin-resistant patients, doxycycline or ceftriaxone can also be used. In primary, secondary, or early latent disease, the treatment of choice is benzathine penicillin G, 2.4 million units intramuscularly as a single dose. If a patient is resistant, doxycycline 100 milligram orally 2 times per day for 2 weeks, or tetracyclines 500 milligram orally 4 times per day for 2 weeks. In late latent or latent syphilis of uncertain duration or tertiary disease in the absence of neurosyphilis, dose is benzathine penicillin G, 2.4 million units intramuscularly weekly for 3 days, for 3 doses. In primary disease, it was single dose. Here we are giving 3 doses on weekly intervals 3 times. And in penicillin allergic patients, doxycycline 100 milligram orally 2 times per day for 4 weeks, or tetracycline 500 milligram orally 4 times per day for 4 weeks. Whereas in neurosyphilis, duration of dose is extended. Aqueous penicillin G is the drug of choice, 18 to 24 million units per day, given intravenously as opposed to intramuscularly. 3 to 4 million units every 4 hours, or continuous infusion is given for 10 to 14 days. Or alternative regime is procaine penicillin, 2.4 million units per day, intramuscularly, plus probenecid 500 milligram orally 4 times per day, both for 10 to 14 days. Anyone knows, can we give doxycycline or tetracycline in children or in breastfeeding? So why it is contraindicated in those? Teeth discoloration in children and hepatotoxicity in pregnant ladies, and also fetal long bone are affected during pregnancy. Topical steroids and cycloplegics are also have a role in anterior uveitis and interstitial keratitis, whereas systemic steroids are used with caution in sight-threatening posterior uveitis or scleritis, but they do have a role. Many ophthalmologists recommend to give up to 40 milligram oral steroid. It is an interesting phenomenon, Jari-Alzheimer reaction. When we start antimicrobial therapy, there is transient worsening of inflammation. When spirochetes die due to treatment, there is a hypersensitivity reaction to treponemal antigens, and there is transient worsening of inflammation. Now we move on to congenital syphilis. It is through transplacental spread. Its early systemic features are failure to thrive, that is, children don't grow properly, they don't gain proper weight according to their age, maculopapular rash, mucosal ulcers, and characteristic fissures around lips. Late systemic features include sensorineural deafness, saddle-shaped nasal deformity. In this, there is collapsed nasal bridge, saber tibia, that is anterior bowing of tibia, Hutchinson teeth, bulldog jaw, and Clutton joints, that is painless effusion in large joints. This is colored photograph. In the first picture, we can see saddle nose with bridge of the nose being depressed. Second picture, we can see severed tibia with anterior bowing, and third picture, we can see Hutchinson teeth, in which there is molar and incisor teeth are triangular shape or peg shaped. Ocular features are anterior uveitis, interstitial keratitis, dislocated or subluxated lens, cataract, optic atrophy, salt and pepper pigmentary retinopathy, Argyll-Robertson pupils. Anyone can tell what is Argyll-Robertson pupil?
Pupils that will fit more on the population as compared to light.
Okay. And what kind of anisocoria we will get in that? We will have mediatic pupil or Mayo's pupil? Mayo's pupil. This is a picture showing interstitial keratitis. We can see there is stromal. In the first picture, we can see stromal vascularization with salmon patch appearance and corneal haze. In the second picture, there are ghost vessels in the stroma owing to resolution of lesion. In the third picture, there is stromal hemorrhage due to these stromal vessels. And in fourth picture, we can see a corneal scar. This is a typical salt and pepper pigmentary chorioretinopathy in a case of ocular syphilis. Again, this is table showing features of congenital syphilis. Before 2 years of age, mucocutaneous rash, periostitis, osteochondritis, chorioretinitis, and retinal vasculitis, producing the characteristic salt and pepper fundus. Whereas in late stage, greater than 2 years of age, they can develop saddle nose, frontal bossing, severed shins, Hutchinson's teeth, and interstitial keratitis. Treatment again under the care of pediatric infective disease specialist, and treatment of choice is again penicillin. Thank you very much.
Okay, so good presentation, good photographs, and you maintained interaction with the audience. Excellent. So, just to recapture what he has said, how will you identify interstitial keratitis?
Stromal vessels, salmon patch, and there will be stromal hemorrhage,
Good.
and the later stages there is called opacity
Opacity
within stroma.
with stoma,
The ghost vessels.
with ghost vessels. Ghost vessels are also called. What are ghost vessels? This was a question asked by, I was asked this question in FRCS examination. I said ghost vessels. One of the examiners did not know what is ghost vessels. The other one, because there are two in one batch, so the other one told him. So we should know what is the alternative name for the ghost vessels. What are ghost vessels? What do you mean by ghost vessels? Good. So non-perfused vessels, vessels which do not have blood flowing through them, they are constricted, only lines which are present there. So these are called ghost vessels. Okay. As for Argyll-Robertson pupil is concerned, I have remembered it with the mnemonic AR, Argyll-Robertson. Accommodation reflects present. So Argyll-Robertson pupil accommodation is present. So whenever there is difference of size, this is called difference in size of pupil is called Korea. So what do you do to step with the next step in anisocoria is you note whether the anisocoria is more in dark or in bright light. For example, Horner syndrome, the pupil is meiotic, small. So if you throw light, then the anisocoria will not be marked because of both the pupils will be constricted. So Horner syndrome pupil will be more prominent when you take the patient to dark. So whether the mesocoria is more in the darkness or in the bright light, that will help you to tell. Now, the syphilitic problem is especially noteworthy that it is treatable. See, 100% treatment can be done easily with penicillin G. So you can, if you have in mind all these features, then the main problem is we do not ask for the tests. We do not suspect syphilitic uveitis. We keep on sort of treating the uveitis element with steroids, and that does not help because the infection will not be treated unless we give antibiotics. So, as he has told all the manifestations, uh, whenever these manifestations are encountered, we should ask for the test. And most of these patients also have positive AIDS because of the similar mode of transmission. So, syphilis was very common in Western countries. It has reduced in frequency. It was never an epidemic-like condition in our country, but now because of the AIDS, it is now again increasing in number. So, any comment? Can we see treponema in microscope? Under microscope, we can see. See, so, in all the infections, first thing we try to do is to isolate the organism and see it under microscope. If it is not possible, then we additionally do culture, and then we do the serological tests. We detect the antibodies present against it. So, infective organisms can be isolated and seen on the microscope. That gives the fastest diagnosis. So, anything else? Hmm. हाँ, हाँ, हाँ. Good. So one should know the name of the Cogan syndrome. It involves the interstitial keratitis and बिल्कुल ठीक है. So ये syphilis can affect any organ. So it is called according to the system which is involved. It can be neurosyphilis or cardiovascular syphilis. So only one system can be involved and the others are spared. So one should have high suspicion of index to rule out all the possibilities of involvement. So as in myasthenia, any nerve paralysis can occur. Any sort of paralytic manifestation may be encountered in myasthenia. Similarly, any organ involvement in any way, eye involvement can occur in tuberculosis and syphilis. See, so there is variety of manifestations in which the syphilis or tuberculosis can present. Okay, thank you very much.